going to continue with our assessment of the abdomen now. In this portion of the assessment, we're going to go ahead and practice our auscultation and percussion. Now, just as before we had the patient lying down with his arms at his sides, we're going to go ahead and go through the auscultation process of this. For this, we'll use our stethoscope. When we do this, we will be first of all assessing the 4 quadrants of the abdomen here, and what we're looking for is to make sure that there is gurgling sound or crackles going through. There should always be these sounds here, just because of the fact that if you ever hear nothing, if you've been listening for about 5 minutes and you don't hear nothing, that would be a case of an emergency, because you're probably looking at something like ischemic bowel. These are the types of things that you need to look for. Also, if you hear that you have very, very high-pitched sounds, or you have hyperactive bowel sounds, those could all be indications for maybe an obstruction or the preliminary symptoms of a possible obstruction that is going to be occurring, or maybe in areas where you hear high-pitched resonance. It might be because you have trapped gas. Maybe there's a lot of pressure in the bowel, and it may be causing that high-pitched sound, or maybe a lot of fluid in the intestines. So all these things are things that can give you a lot of hints as to what is going on in the bowels. So anyways, you're going to go ahead and auscultate as such, making sure that you hear all 4 quadrants, right upper quadrant. And then I hear perfect gurgling and crackles continuously. Also, you may hear hyperactive bowel sounds when a patient is hungry as well. That's normal. So, if you haven't heard any types of sounds when you're auscultating, like I said before, you want to sit there and at least wait about 5 minutes to see if you hear anything. If you don't hear anything at that time, you need to make it known to the physician that there is no bowel sounds. This could be a possibility of some rigidity of the abdomen there, and like I said before, maybe some ischemia. So you need to make sure that you assess that. You should hear anywhere from 5 to 35 different crackles or gurgles within a 5-minute period. And like I said before, very important to assess that portion. So when you're assessing, like I did right now, you're going to be using your diaphragm for that. And also what you're looking for is you want to assess your liver as well as your spleen for any type of friction rub. If these organs are swollen or inflamed, you'll hear a little bit of a rub, and it's just them rubbing up on the cavity there or upon other organs. So when you do this again, you'll be hearing the 4 different quadrants here, and then to the right, anywhere from a little bit below the costral margin, maybe to a little bit above it, is where your liver lies. So you want to position your stethoscope there to try to hear for this rubbing. And you also want to do your spleen. Your spleen lies in your left upper quadrant. And you'll hear this on respiration, on inspiration, as your diaphragm moves down and pushes on these organs. And when you finish with that, you can always assess also for bruits. You want to make sure that you do that. A bruit is something that you're gonna be hearing intermittently, and it's just maybe some turbulence or tortuosity of some of the vasculature. And the way that you are able to auscultate that is by knowing your anatomy. First of all, you need to know that the aorta comes down the center here, posterior to all the other organs, and then sends out these extra branches out into the kidneys, a little bit below the costral, where the costral margin begins to separate here. About this area, right above the umbilicus, is where you would have your kidneys on each side. Your right a little bit lower than your left. As you move down, the aorta again bifurcates into your iliac arteries, and that happens right below the umbilicus. As you move down into the pelvic region, that's where you'll have your femoral arteries there. So you want to make sure that you assess all of these areas for any bruits that may indicate maybe some turbulence in the blood that could possibly cause maybe hypercoagulability, or maybe it's the fact that there's an aortic aneurysm there. So these are different things that can pinpoint what's going on there. So when you do this, you'll do this as such. You'll locate your costral margin and the angle right here, right where your xiphoid process is. Right below it, you'll go ahead and place your stethoscope, and you'll listen to any swooshing sound. If you don't hear anything, you'll go ahead and go a little lower and to the right, trying to hear for the same thing. And this would be an intermittent. With every pulse, it would go whoosh, whoosh, whoosh. And then you go on your right. And sometimes you'll hear more bowel sounds than you do anything else. But if there was a bruit, you'd be able to hear it. As we come further down, now we're going to go a little bit to the right. Now we're checking the iliac arteries, right and left. And then we go further into the pelvic region, and we're listening at the femoral artery region for any bruits. And then lastly, we're going to place it, the stethoscope just around the umbilicus site, and we're looking for a venous hum. Now, the difference between a venous hum and a bruit would be the bruit is related to the pulse. It's associated with that pulse. It's an intermittent sound. The venous hum is just continuous, low-pitched and continuous. And if you hear this, that is basically just the portal venous system and it's just showing you that there's a lot of circulation through there, and maybe some turbulence there as well. And the reason you check around the umbilicus side is because that's where your mesenteric artery connects to the intestines, and then the portal vein brings it back over to the liver, all that blood back over to the liver, the deoxygenated blood. So it would be around this area where the mesenteric artery ends up becoming into the portal vein. So no venous hum there. Okay, so that pretty much completes the auscultation of the abdomen. Now we would go next into the percussion of the abdomen. Now when we do this, there's two major organs that we're focused on, and that's the liver, the single most largest organ of the body, and also on the spleen here on the left side. And what we're looking for is any enlargement or any atrophy of the liver. Same thing with the spleen. So again, you need to know your anatomy when you're looking at this. You need to know where to locate these two organs, knowing that the spleen lies very closely to the stomach here. You've got the stomach here, you've got the spleen here, and then you've got the splenic flexor, which is just the transverse colon, making that sharp turn down into the descending colon. So you've got all these different things in this area. So you need to be aware of that, just because of the fact that just because you hear a dullness in percussion, it doesn't always mean that you may have splenomegaly. Sometimes it's just the fact that you may have a lot of feces in that area of the colon at the time. So, first of all, when we percuss, we do it as such. We kind of tap our middle finger here in this area over on our left finger, over the nail. And what we're doing is we're hearing for what type of sound it makes. And you can tell when it is hollow, and then when you get up into a place that's solid and not filled with air, because the sound changes. It goes from high-pitched to low. Okay, so the way that we use this is in reference to the liver. Most of the time you see the liver right here below the nipples, and it'll come over this way. Right side will drop a little lower than the left. So we would go ahead and start from the midclavicular line coming down and start percussing upward to start seeing where the bottom of that liver lies. Okay, so it looks like it lies right there. And then I have already made a marking there prior, so make another mark in there. And then after we determine where that is, then we would go and start percussing from the top to figure out where the top of it is. And then we would go down, and I mean, you can do this as another option. You could also measure it from the sternum down as well. And I've already marked it here where I found it. And you keep going down until you hear higher pitch. And then what you do is you go ahead and measure the length of these. And normally what you want to see, the measure between the two distances, which is just the vertical liver span, it should be 6 to 12 centimeters. So if I look here on my ruler, say it looks like it's at about a 9 centimeters. So that's very much normal. And then when you look at the middle mark, it should be anywhere from 4 to 8 centimeters. So if I measure it here, and it looks like it's right about an 8. So that's normal there. And then once you have located and seen what size the liver is, then you can go ahead and assess the spleen. Now the spleen is difficult, like I said before, just because of the fact that, you know, if I come over here and I'm at the lower portion, the last intercostal space, and I'm just kind of just percussing around all areas to see what size the spleen is, I might be surprised and I might say, oh wow, I think the spleen is enlarged, but in fact, you know, if the patient just ate a couple of hours ago, he might have feces in that area, and he may be mistaken that, or maybe the stomach is filled with food and you're mistaken it for that. So another way to do it is you can go ahead and ask the patient to breathe in, and you percuss the last intercostal space, and then you breathe out. And then you want to hear that when he breathes in and he breathes out, the sounds are always tympanic. If you hear a dullness, it's possibly because the diaphragm is moving the spleen downward, and that's when you start hearing the dullness. So another reason why, or another technique we could use with breathing in and breathing out in reference to the liver is whenever we're checking the liver, we ask the patient to go ahead and take a deep breath in and hold it. And then when he holds it, we go ahead and percuss again. Mark our space on the lower border of it. Go ahead and breathe out. And then we're able to measure the previous lower border from the current border, and it looks like it's about 2 centimeters. So 2 to 3 centimeters is what you're normally looking for, because at this point in time, when he breathes in, he expands his lungs, his diaphragm drops as it contracts to expand these lungs. Everything should move downward. So in this case, you know, that would be something that we would be looking for. Okay. Now, okay. Another thing that we need to be looking for is the gastric bubble, is what they call it. Now, the way we differentiate between the stomach and the intestines is the stomach. Normally, what you hear in the stomach is a lower pitch than what you hear in the intestines. So, also keep in mind that your anatomy is important. You should know that your stomach lies here on the left upper quadrant. So what you would do, you would locate the stomach, okay, and you're hearing for a tympanic pitch, but kind of on the low side, and then you move down, and then you hear intestine because it's higher pitched. Now, last but not least, we're going to ask our patient to go ahead and sit up, and then we're going to go ahead and perform a test of the kidneys, percussing the kidneys. So what we're going to do is we're going to take our left hand and put it right below, what's it called? Right above, or right on the costovertebral angle here, where the kidneys are located. And then we're going to take our other hand on the ulnar region, and we're just going to percuss and tap on our palm. Now, the patient should not feel pain when we do this. He should just feel a thud. Okay, so that concludes the auscultation and percussion. Tune in for the next video, and we will be talking about the palpation.